Hello everyone, welcome back to the channel. Today I'll be dealing with the longest chapter in community medicine, that is Epidemiology of Communicable Diseases. So I'll be dealing with this over 3 videos because it's impossible to cover it all in one video and keep it brief. So we're starting with respiratory infections, and the first one here is smallpox, also caused by the variola virus. So I need to know the brief history about smallpox, its case definition under IHR, that's International Health Regulations, and smallpox eradication surveillance. It's very brief, not much to remember. It's easy. So the next one is monkeypox or mpox. So you need to know the hosts and how the disease is transmitted, the agents and the high risk groups included, and the incubation period of the disease, and clinical features over 2 phases, that's the invasion period and the skin eruption, diagnosis, treatment, vaccination, and prevention. Any contagious disease can be described under these headings that I've just listed. Now, coming to chicken pox, there's a small problem statement that's basically like a brief history about the disease, and then it starts with the epidemiological determinants. Firstly, the agent factors. Under agent factors, we have the agent, the source of infection, infectivity, and the secondary attack rate. Under host factors, we have age, immunity, and pregnancy. This is very important. And under environmental factors, we have cool, dry weather, which can facilitate the transmission of the disease. By droplets and droplet nuclei, we'll also look at the transmission of monkeypox virus, which is parenteral and enteral. And then the incubation period for monkeypox, it's 6 to 13 days. For chickenpox, it's 14 to 16 days. Then we have clinical features, which can broadly be categorized into pre-eruptive stage and eruptive stage. You have to describe the distribution, the rapid evolution, the pleomorphism of the rashes, and the fever pattern. An important table on smallpox versus chickenpox. Then any complications, diagnosis, control, and prevention by 3 methods: varicella zoster immunoglobulin, VZIG, vaccines, and post-exposure prophylaxis. Next, we have measles, also known as rubeola, which is caused by an RNA virus, which has only one serotype. So, in the problem statement, and epidemiological determinants, under which we have agent factors again, under which we have to describe the agent, source of infection, infective material, communicability, and secondary attack rate. And then host factors like age, sex, immunity, and nutrition. Immunity and nutrition kind of go hand in hand. And then environmental factors, which are literally the same as the previous disease. Environmental factors are the same for all respiratory diseases. Cold, cool weather facilitates the transmission, which is also usually by droplet methods. And communicability, you have to remember 4 days before rash onset to 4 days thereafter. Incubation period is 10 days for fever and 14 days for the onset of rash. And clinical features can be divided into prodromal phase, an eruptive phase, and a post-measles stage. The key words, remember, is vesicular rash for chickenpox. And coming back to measles, we have the dusky red maculopapular rash starting behind the ears. Then we have the post-measles stage. Then we have the complications, under which the most common complication is otitis media, but the most deadliest complication is pneumonia and SSPE, that is subsclerosing panencephalitis. Then you have treatment and a small note on co-infection with chickenpox. Under prevention, we need to know about the measles vaccine, the composition, its indications, contraindications, administration, the time and site, the reactions, provision of immunity, vaccination of contacts, and adverse drug effects. And then also we have the measles immunoglobulin, and then a short note on measles rubella strategic framework 2021 to 2030 and outbreak control measures. These are not that important, so you can skip it if you want. Now, coming to rubella, we have the history of rubella, and then ED, epidemiological determinants, agent factors, which are agent, which it's an RNA virus with one serotype only, source of infection, and communicability period. Then host factors, we have age and immunity, and environmental factors and transmission are same as above, the previous diseases. And incubation period is 2 to 3 weeks. Clinical features, here describe the prodromal stage, lymphadenopathy, rash, and complications. Here we have minute, discrete pinkish rashes on the face that spread rapidly to the trunk and extremities. This is characteristic of a rubella rash. Then we have diagnosis, then congenital rubella syndrome, which is a bit important. Then a short note on prevention, in which I have the rubella vaccination. Now it's joined with MMR, mumps, measles, and rubella. And talking about mumps, which is the next disease listed in the book, we have the problem statement, in which it's a RNA virus with a single serotype again. And agent factors, we have agent, source, communicability, and secondary attack rate. Host factors, we have age, sex, and immunity. And environment factors and transmission are the same for any respiratory disease. Incubation period is 2 to 4 weeks. Know the clinical features of mumps plus the various complications. And prevention, vaccination, and surveillance, in which you have the case definition of mumps, in which you have clinical case, laboratory confirmed case, and an epidemiologically confirmed case. And then also short note on mumps control. Next, we have influenza, in which, of course, we have the problem statement. And then we have the epidemiological determinants, in which have agent factors. The agent has 4 serotypes A, B, C, D, reservoir, and then source, and then infectivity period. Under host factors, we have age, sex, immunity, and human mobility. Under environmental factors, we have the season and overcrowding. Incubation period is 1 to 4 days. We need to know the general pathogenesis plus clinical features, especially Ray's syndrome. And then we have the various subtypes, and seasonal influenza, bird or avian influenza, H5N1, whose incubation period is 2 to 5 days. You should know about the transmission, diagnosis, treatment, prevention, and vaccine for the same. And then swine flu, that's H1N1, which caused the pandemic influenza A 2009. You should know the incubation period is 1 to 4 days. And the case definitions, that is the suspected case, probable case, and confirmed case. And the clinical features of uncomplicated and complicated or severe swine flu. And very important table, differentiating influenza and COVID-19. Signs and symptoms of progressive disease, lab diagnosis, infection control, and then influenza vaccine, of which there are 3 types: egg-based, cell culture, and recombinant. Egg-based are usually inactivated influenza vaccines. There are live attenuated vaccines as well. So you should know the side effects and contraindications of each vaccine. And there's also antiviral therapy with 3 precautions to keep in mind. And the most common drugs are neuraminidase inhibitors, of which oseltamivir is the most commonly used, and chemoprophylaxis and surveillance. Now we have diphtheria, in which you know the problem statement, epidemiological determinants, in which you have agent factors, in which for the agent you have to know that this is a toxin mediated disease. Under source, you have to know the cases and the carriers, infective material, and infectivity period. And on host factors, you have age, sex, and immunity. And environmental factors are the same. Transmissions can be via droplets or via contact. And the various portals of entry can be respiratory or non-respiratory. Incubation period is 2 to 6 days. And you should know the broad clinical features. So the keywords here are pharyngotonsillar pseudomembrane and a bull neck appearance, which can extend into the larynx. So you'd know the methods of diphtheria control. Firstly, you have to deal with the cases and carriers, which involves early detection, isolation, and treatment of cases and carriers. And you have to deal with contacts, and then you have to deal with the community level. Under immunization, you have combined or mixed vaccines, single vaccines, and anti-sera. Under combined or mixed vaccines, you have various options like DPT, DTPW, DPA, and Pentavac is what we use in our country. So you should know the age, doses, mode, reaction, and contraindications of each. Moving on to pertussis, we have the PS and the epidemiological determinants, agent factor as usual. This is also toxin mediated disease. You should also know the source, infective material, infective period, and the secondary attack rate here. Host factors are the same: ASI, age, sex, immunity, and environmental factors. Transmission is also the same, droplets. Incubation period is 7 to 14 days, and clinical features are in 3 stages: catarrhal stage, paroxysmal stage, in which you have rapid consecutive coughs followed by a deep high-pitched inspiration, which we call as a whoop, which is frequently followed by vomiting. And then, of course, the convalescent stage or recovery stage. And pertussis control, you have to deal with cases, contacts, and also active and passive immunization. Next, we have meningococcal meningitis. So know the PS, the ED, the agent factors in which your agent is Neisseria meningitidis, which has 12 serotypes, and then the source, the communicability period, the host factors, which is ASI, and environmental factors and transmission. And incubation period is 3 to 4 days. Clinical features, it can be usually asymptomatic and susceptibility decreases with age. And prevention and control, you have to deal with cases, carriers, contacts, mass chemoprophylaxis, and vaccines, which can be polysaccharide vaccine or conjugate vaccine. Next up, we have acute respiratory infections. Here it's basically a broad discussion on various acute respiratory infections, but it then moves on to discuss HIB, that is Haemophilus influenzae type B serotype. So to deal with the ED, the usual agent factors, host factors, risk and environmental or risk factors and transmission, and control of HIB to do the clinical assessment and then a physical examination in which you see the breathing rate over 1 minute strictly over 1 minute, and then chest indrawing, stridor, wheeze, drowsiness, fever or hypothermia, severe malnutrition, and cyanosis. Now we have management measures under IMNCI guidelines for pneumonia, which can be categorized into kids less than 2 months of age and between 2 months to 5 years of age. Then acute upper respiratory infections. And then under immunization, you need to know about measles immunization, HIB immunization, and PPV23 or PCV vaccines for pneumococci. An integrated global action plan for prevention and control of pneumonia and diarrhea, whose deadline is 2025. Not that important. We then move on to severe acute respiratory syndrome or SARS, which you have the incubation period as 2 to 7 days, and the transmission can be by droplets or contact or by aerosols. Then you know the case definition of a SARS case plus laboratory confirmation, which can be via RT-PCR or real-time PCR, and ELISA and immunofluorescent assays, and epidemiological determinants, which is the same as usual, and complications, treatment, prognosis, and prevention. Now we have a virus that has disrupted all of our lives since the past 5 years and slow down time for us. Thank you. COVID 19. We have the problem statement, the variants, which have variants of concern and variants being monitored, and the transmission of COVID 19. The incubation period is 2 to 14 days. You also know the communicability period and the clinical spectrum of COVID 19, which can be mild disease, moderate disease, severe disease, or critical disease. Under critical disease, you have ARDS, acute respiratory distress syndrome, and sepsis. And you should also know the risk factors for severe disease. Now, coming to the case definitions, which is very important, you should know about the suspected case, a laboratory confirmed case, and contacts, that is high risk and low risk contacts definition. And then post or long COVID conditions, you should know what can predispose the general symptoms, RS or CVS, and neurological, digestive, or other risk factors, plus the black fungus infection, diagnosis and treatment of the same. How to diagnose COVID 19? You have diagnostic and screening testing. And the methods are molecular tests, in which you have to know about sample collection, bronchoalveolar lavage or sputum or tracheal aspirate from the lower respiratory tract, and nasopharyngeal or oropharyngeal swabs for the upper respiratory tract. The procedure to collect the same, and you can also combine a nasal and throat swab, and NAT plus CT score, that cycle threshold, in which less than 25 indicates a high viral load, more than 35 is negative, then antigen testing and serology. The other methods include chest imaging, in which you have to see chest x-ray, CT or ultrasonography, and then laboratory examination of blood. And then management, you have to know the algorithm to manage COVID 19 cases, home care, prevention of complications, and post COVID management protocols on an individual level, a community level, and a healthcare facility level. Then you also have public health surveillance, which involves essential surveillance, global surveillance, and weekly aggregated reporting. And there are WHO categories for the transmission patterns, then methods of prevention of COVID 19, and vaccines. 6 vaccines were approved for emergency use, and it's only later on that the vaccines we know came into the market. That is Covishield, Covaxin, Sputnik 5, Pfizer, BioNTech, and Moderna vaccines. And also a short note on dead body management. The algorithms look scary, but you need to know just two measures under each of the broad headings there. That would suffice. Now, coming to the next disease, which is also pretty important, tuberculosis or TB. You know the problem statement, the age and sex distribution, and epidemiological indices relevant like incidence, prevalence, mortality, case fatality rate, case notification rate, case detection ratio, and prevalence of drug resistant cases. Another thing to be noted in TB HIV co infections, deaths must be classified under HIV according to ICD 10. And then you have the case definitions, in which you define a presumptive case, a bacteriologically confirmed case, and a clinically diagnosed case, which can be classified based on anatomical site into pulmonary and extrapulmonary TB, and based on HIV status into HIV positive, HIV negative, and HIV status unknown, and based on history of TB treatment into new case or a previously treated case, which can be further categorized as a relapse, treatment after failure, treatment after loss to follow up, other previously treated patients, and unknown history of previous TB. Then you have under drug resistance TB, you have monoresistant, polydrug resistant, multi drug resistant, extensive drug resistant, and rifampicin resistant. So, what exactly is polydrug resistance? So, resistance to more than one line of anti-TB drugs, except isoniazid and or rifampicin, is called polydrug resistance. Multi-drug resistance would involve at least both isoniazid and rifampicin, which are abbreviated as H and R. Extensive drug resistance involves resistance to one fluoroquinolone or at least one of the three second line drugs, that is capreomycin, kanamycin, and amikacin, with multi-drug resistance. So this is how we define the same. Then you have the definitions for treatment outcome. Then we have the definitions of the various treatment outcomes, in which patients are categorized broadly into drug susceptible and drug resistant cases. So we have cured cases, treatment completed, treatment failed, treatment success, lost to follow up, died, not evaluated, and cohort cases. Then we move on to the natural history of TB, in which we have the agent factors, in which you have to know about the agent, the source, and communicability of the disease, and the host factors like age, sex, heredity, nutrition and immunity, and social and environmental factors. The transmission of TB and the incubation period, which can stretch from weeks to months or even years. And it takes 3 to 6 weeks for a positive tuberculin test after inoculation of the bacilli into the body. And under control, we have curative and preventive control measures, which involve case finding in the public sector. So we have strategies for case finding like passive case finding, intensified case finding, active case finding, and vulnerability mapping. Then we have screening strategies like community screening and institutional screening. And then we have various case finding tools that we use, which involve sputum smear microscopy, which can be either the Zeal-Nielsen or acid-fast method, or LED fluorescent microscopy method. And then we have culture, which can be solid or automated. Under solid, we have the LJ medium, Lowenstein-Jensen medium. Then drug sensitivity testing, we have PST or proportionate sensitivity testing for MGIT 960 system. and then an economic variant of 1% PST using LJ medium. And then you have rapid molecular diagnostic tests like line probe assay and CB-NAT or TrueNAT, nucleic acid amplification testing, and other supportive tools like chest X-ray, tuberculin skin tests, and interferon gamma release assays, IGRA. We then have all of these what I've circled are the important ones which you should know. And then we have collection of sputum samples. To summarize, two samples over 2 days. You should know when on each day, at what time, and how you collect the sample. And you should also know the AFB stain procedure, slide reporting, and false positives or negatives. And then fluorescent microscopy, for which use the auramine stain, radiography, and the tuberculin test, which I know about the Mantoux test, the site, the procedure, and the adverse effects of the test, classification of various positive TSTs, and two-step testing. And then, of course, IGRA. Then we move on to another important part, that is chemotherapy, in which the anti-TB drugs can be categorized into first, second, and third line. In parts, it only talks about first and second line. First line, you have bactericidal, that is HRZ, isoniazid, rifampicin, and pyrazinamide. And bacteriostatic, you have ethambutol. Streptomycin is not considered now. And on the second line, we have fluoroquinolones, ethionamide, capreomycin, kanamycin, amikacin, cycloserine, thioacetazone, macrolides, bedaquiline, and dilamanid. Then we learn what is two-phase chemotherapy, short course chemotherapy, and what is the dot strategy. This is a very frequently asked question in exams and a very important for competitive exams as well. Then daily dose regimens in NTEP for drug-sensitive TB. You have to know about the pre-treatment counseling and evaluation, the recommended regimen, what are the fixed drug combinations or FDCs, doses for adults and kids over various weight bands, and follow up clinically and laboratory wise. Then you have drug resistant TB, which medicines are grouped into group A, B, and C. Group A has levofloxacin or moxifloxacin, bedaquiline, and linezolid. Group B, you can add one or both of clofazimine and cycloserine or terazidone. Group C, you have to add to complete regimen, and when medicines from A or B can be used. So you have ethambutol, delamanid, imipenem, cilastatin or meropenem, pyrazinamide, amikacin, ethionamide or prothionamide, and para-aminosalicylic acid. We also have the inclusion criteria for newer drugs like bedaquiline and delamanid, and exclusion criteria for the same. And other new regimens, including the inclusion and exclusion criteria, like shorter oral bedaquiline containing multi-drug resistant regimen plus injectables, isoniazid mono or poly-drug resistant TB regimen, and longer oral multi or extensive drug resistant TB regimen. And then what happens when treatment is interrupted, and also the latest BPALM regimen, the eligibility, dosing, and duration of the regimen, monthly patient-wise box for drug-resistant TB patients, and then a small part on childhood TB, the diagnosis, the algorithm to treat, preventive therapy, and how to manage drug-resistant TB in kids, and then also how to manage TB in pregnant and lactating women. And then BCG vaccination, Bacillus calmette-guerin. The aim of vaccination, the composition of the vaccine itself, the types, dosage, administration, age, how to manage pneumonia after vaccination if it occurs at all, complications, other complications, protective value, revaccination, contraindications, direct BCG vaccination, the impact of BCG vaccination, and BCG and HIV infection and combined vaccination. We also learn about the Adult TB Vaccination Initiative and TB Preventive Treatment or TPT, in which you have to identify the at-risk population, see the eligible groups, that is people living with HIV and all household contacts of pulmonary TB, other risk groups, and tests for TB infection and TPT for each risk group that I listed above, and the contraindications. Then we all deal with rehabilitation, TB surveillance, and the role of hospitals in the same. And then we discuss drug resistance in detail. Drug resistance can be classified into primary or pre-treatment and secondary or acquired drug resistance. So the causes can be microbiological, clinical, or programmatic. We then see other comorbidities and special situations that can complicate TB, like bad nutrition, alcohol use disorder, TB with HIV, in which is described in detail. You know the epidemiological impact of TB HIV co-infections, which can cause reactivation of latent TB, and it can also predispose to primary infection, recurring infection, and increase the incidence of TB in the community. And treatment in people living with HIV and why it's more difficult. There are four important reasons. It can cause a higher frequency of negative sputum because the immunity is decreased, the TST fails, and the chest X-ray won't be suggestive of TB. And this can also increase the frequency of extrapulmonary TB. We also deal with the treatment of immune reconstitution inflammatory syndrome or IRIS and isoniazid preventive therapy for people living with HIV. The previous point was diagnosis, not treatment. I stand corrected. And then TB with diabetes and TB with tobacco. And a short note on the end TB strategy. And TB strategy not usually asked, so it's fine. You can skip it. We then move on to the next type of communicable diseases, that is intestinal infections. So we start with poliomyelitis. We see the problem statement of poliomyelitis. Currently, wild poliovirus 1 is what's circulating across the globe. And then polio eradication and endgame strategic plan, which you can skip if you want. And the steps involve introducing IPV and the switch from trivalent OPV to bivalent OPV, that's oral polio vaccine. IPV is inactivated polio vaccine, and the eventual withdrawal of all OPV. So the switch happened from 18th April to 1st May 2016, along with the containment of wild poliovirus 2, which developed resistance. Then the polio eradication strategy 2022 to 2026, and then the fractional dose IPV versus normal IPV. There's a table given, you can read that. And then polio surveillance, in which you have acute flaccid paralysis surveillance and the steps to do the same. We have to first find and report kids with AFP, transport their stool samples for analysis. In that, you have to isolate the poliovirus and then map the virus for the which serotype, etc. And then we have environmental surveillance along with surveillance indicators, which are completeness of reporting, sensitivity of surveillance, completeness of case investigation, completeness of follow-up, and laboratory performance. So your reporting is considered complete if 80% of routine surveillance reports are on time and are representative of the geography and demography of the region. This includes zero reports as well. Zero reports means that there are zero cases right now. Sensitivity of surveillance, at least one non-polio AFP annually must be reported per 100,000 population. And the age of that one non-polio acute flaccid paralysis case must be less than 15 years. So completeness of case investigation would involve a full clinical plus virological investigation of all AFP cases, which should be more than 80%, plus adequacy of stool specimens. The important thing to note about the stool specimens is 2 stool specimens of sufficient quantity collected at least 24 hours apart within 2 weeks of AFP onset. It should arrive with proper documentation by reverse cold chain. Only then will you consider a stool sample as adequate. And then adequacy of follow-up, more than 80% of the cases must be followed up 60 days after the onset of AFP. And laboratory performance, you must get it tested in a WHO accredited laboratory within Global Polio Laboratory Network. Then we also deal with vaccine derived polio virus, which is the most common is due to Sabin 3 vaccine. It can be categorized into community, immunodeficient, and ambiguous VDPV. Plus, there are 7 points given in the textbook on why VDPV is a matter of concern. There was a VDPV outbreak in Nigeria and DRC a few years back. We come to the epidemiological determinants of polio, which are the agent factors, agent, reservoir, infectious material, which can be feces or oropharyngeal secretions, and the period of communicability. Host factors, you have age, sex, risk factors, and immunity. Then we have environmental factors, which are contamination, overcrowding, and poor sanitation. Transmission can be by fecal or droplet transmission. And then incubation period is 7 to 14 days. The clinical features, you have an inapparent infection or subclinical infection, which is 96% of the cases. Then abortive polio or minor illnesses that occur in 4 to 8% of the cases. Then non-paralytic polio in 1% of the cases. And then the most dreaded one, that's paralytic polio, which occurs in less than 1% of the cases. Plus an important diagram showing the time course of events in a polio virus infection. Must know. The most common cause of death is respiratory paralysis in paralytic polio. There is no specific treatment, so you have to deal with prevention, in which you have immunization. First, you have the inactivated polio vaccine or SALC, which has at least 40 units, 8 units, and 32 units of type 1, 2, and 3 respectively. You can remember it this way: 40 is equal to 8 plus 32. And then the adjuvants used in the vaccine, the route, important note, avoid freezing of IPV. Then the course, immunogenic action, how the antibodies are produced, and pros, cons, risks, and contraindications. Next, we move on to the oral vaccine, that is Sabin, live attenuated viral vaccine, using primary monkey kidney or human diploid cell cultures. You have to know the usual things for each vaccine, that is the dose, mode or route, development of immunity, pros, contraindications, complications, storage of stabilized and non-stabilized oral vaccines, and the sequential administration of IPV and OPV. There's an important table differentiating IPV versus OPV. The famous slogan for this is "Do Boond Zindagi Ki." Then you have human normal immunoglobulin, which is now not relevant because of widespread active immunization. Then epidemiological investigations of polio, strategies for polio eradication in India, and then the line listing of cases, mopping up, and pulse polio immunization. So the last case of polio in India was from Howrah or Kolkata in 13 Jan 2011, and India was declared polio free on 27th March 2014. Our next disease is viral hepatitis. So we deal with each hepatitis virus in detail. Hepatitis A, you know the problem statement. There are high, intermediate, and low levels of infection. And the epidemiological determinants, I'll be using these abbreviations from now on. Agent factors are AF. You should know the agent, it's the drug resistance, reservoir, infectivity period, infective material, and viral excretion. Host factors, age, sex, and immunity. There's an equal incidence across both sexes for hepatitis. As for polio, there's a higher incidence in males. And then we continue with the environmental factors, which are the same as that for polio. Fecal, all these are intestinal, so fecal transmission is always there. There's a very interesting and rather puzzling paradox in which improved hygiene and sanitation in fact increases the morbidity from infection with entering viruses. So then we continue to the modes of transmission, that are feco-oral, parenteral, and sexual for hepatitis A. Incubation period is 10 to 50 days. Clinical features, you see there's a important diagram, and then you also see the outcomes of the disease, which can be inapparent infection, icteric disease, complete recovery, chronic disease, and mortality. You also know the diagnosis, and another important diagram showing the immunologic and biologic events associated with human hepatitis A infection. Then the prevention and containment of viruses, which involve the control of reservoirs, control of transmission, and control of susceptible population. Reservoir control is actually a bit difficult because of these reasons. Fecal shedding is extremely high during the incubation period. There are a huge number of subclinical cases. There is no specific treatment because it's viral. And low socioeconomic profile of patients is also another factor to consider. For the susceptible population, we have vaccines and human immunoglobulins. Vaccines can be formaldehyde inactivated or live attenuated. We then move on to hepatitis B, which is also known as serum hepatitis. So, you know the problem statement, the epidemiological determinants, agent factors, you have agent, reservoir, infective materials, resistance, and communicability period. Host factors, you have age, high risk groups, HIV co infection, and humoral and cellular responses. And of course, the environmental factors. There's an important diagram showing the course of typical acute hepatitis, which you use even in microbiology as well. Then the modes of transmission should be parental, perinatal, sexual, and others. The incubation period is 30 to 180 days. Then clinical features are similar as hepatitis A, but you have an increased risk of hepatocellular carcinoma with liver cirrhosis if it occurs. Then diagnosis, there's a table showing the various serological patterns of hepatitis B infection. We then learn about the prevention and containment, which you have HBV vaccine, which is included in Pentavac. Then HBIG for high-risk groups and needle stick injuries, especially. Passive active immunization and others measures involve screening. There is no other specific treatment per se. We have chronic HBV, HCV infections. Separate algorithms for HBV and HCV are listed. If you are interested, you can read that. There are 5 C's here: consent, confidentiality, correct results, counseling, and connection. That is linkage to preventive treatment and care services. These are listed by WHO. Then you have surveillance measures categorized into acute hepatitis reflecting new infections, chronic prevalent hepatitis, and how to manage the sequelae of and the various sequelae of hepatitis, that is hepatocellular carcinoma and liver cirrhosis. Then a small note, which is not that important, on global health sector strategy on viral hepatitis 2022 to 30 and targets for 2030. Then we have hepatitis C virus, which is a transmission which can be parental or vertical. Incubation period is 2 weeks to 6 months. The clinical features, 80% of them are asymptomatic, but the rest you have fever, fatigue, and vomiting, non-specific class type B symptoms. Then diagnosis, we have recombinant immunoblot assay or RIBA. Then you have treatment, which involves direct antiviral agents, but they are very, very costly. There's an important table which can help you in your revision that shows HA versus hepatitis A versus hepatitis B versus hepatitis C virus. Then under prevention, you have primary, secondary, and tertiary prevention. There is no vaccine against hepatitis C because of its high mutation rate. Moving on to hepatitis E, it undergoes fecal-oral transmission with an incubation period of 3 to 8 weeks. It's mostly asymptomatic. Symptoms occur usually in young adults between 15 to 40 years of age, and very rarely it ends in acute permanent hepatitis, which is fatal, and you have a higher risk in pregnancy. Diagnosis, treatment, and prevention, as usual. Then hepatitis D virus. D for dependent. It's dependent on hepatitis B for infection. You know the geographic distribution, the transmission of the virus, which is same as HBV. Diagnosis, there's no specific treatment other than pegylated interferon alpha and prevention. Then hepatitis G, there's nothing important. You can skip it if you want. Then we move on to acute diarrheal diseases. Then you have the definition of diarrhea, then the clinical types of diarrhea: acute watery, acute bloody, persistent diarrhea, which is more than 14 days, and diarrhea with severe malnutrition. Then you have the problem statement plus diarrhea prevention indicators, treatment indicators, and indicators of use of ORS therapy. Then the epidemiological determinants, which are for agent factors, you have viral or bacterial and other agents. Viral, the most common is rotavirus. Bacterial, the most frequent are cholera, E. coli, salmonella, and shigella. Other agents, you have amoeba, giardia, cryptosporidium, cryptosporidiosis, and the reservoirs you should know as well. Host factors are age and nutrition are important. And epidemiological factors: warm season favors the spread of bacterial ones, cool seasons favor the spread of viral enteric infections. Then you have the modes of transmission, of course, fecal-oral. Then control of diarrheal diseases. There's WHO recommendations for a diarrheal disease control program, which are as follows. Short-term measures involve appropriate clinical management using the following measures. ORS, you should know the types, components of ORS, the instructions to the parent while administering ORS to a child, and the various precautions to take while you take ORS. Remember, real ORS packets are WHO certified. Do not buy fake fruit juices which are certified as ORS. It's an ongoing dispute and I hope it's resolved soon. Then you have IV rehydration, which involves ringer lactate and DTS, that's a diarrhea treatment solution. Then maintenance therapy, appropriate feeding, chemotherapy, which you should know the drugs that are not to be administered during diarrhea, and zinc supplementation. Now coming to long-term measures, you need to improve MCH, that's maternal and child healthcare, which will improve maternal nutrition and improve child nutrition by promoting breastfeeding, appropriate weaning practices, supplementary feeding, and vitamin A supplementation. Then you have preventive strategies like improving sanitation, health and education, and immunization, and of course other measures to prevent future epidemics. Under immunization, you discuss in detail about the rotavirus vaccine, which is live attenuated and oral, and of two types, Rotarix and Rotatec. Rotarix is a monovalent human rotaviral vaccine. Rotatec is a pentavalent bovine human reassortant vaccine. And there's a short note, it's not important, on GAPPD, a diarrheal disease control program in India. Next up, we have cholera, in which there's a problem statement describing how it is in the world and across India, and the epidemiological features in India, in which you have long-term carriers, diminished but continuous transmission, which is asymptomatic, that helps tide through the inter-epidemic periods, and of course, it can exist as a free-living organism in the environment too. Then we have the general epidemiological determinants, in which you have agent factors, under which you have agent. We should know the Gardner Venkatraman classification of Vibrio cholerae, which I shall run through briefly. So serogroups, you have O1, O139, and non-O1 or 139. Under biotypes, O1 can be classified into classical and L-TOR biotypes, and both of these biotypes can be classified into Ogawa, Inaba, and Hikojima serotypes. L-TOR Ogawa serotype is the most common here in India. Also, L-TOR quarantine station, Egypt, 1905 is where that biotype gets the name from. A small note on tests to distinguish L-TOR from classical. So, and then we also deal with resistance, toxin production, reservoir, cases and carriers, infective material, infective dose, and period of communicability. And then carriers can be classified into preclinical or incubatory carriers, convalescent carriers, contact or healthy carriers, and chronic carriers. Moving on to the host factors, they have age, sex, equal incidence across all sexes, gastric acidity, population mobility, and economic status, and immunity. And environmental factors are similar. like bad sanitation, low socioeconomic status, etc. Modes of transmission, we have fecally contaminated water, contaminated food or drinks, and direct contact. Incubation period is 1 to 2 days, which is pretty short. Then we deal with the pathogenesis of cholera. Then the clinical features, which can be which can be described in a stage of evacuation, stage of collapse, and a stage of recovery. And a smaller term LTOR as well, which more asymptomatic, lesser secondary cases. Chronic carriers are frequent, and it also has a higher extraintestinal survival rate. The bacillus, not the cases. Then lab diagnosis, stool collection, which has to be collected in a rubber catheter with transport medium and a rectal swab. You can also collect it as a rectal swab without transport medium, which is the Venkatraman Ramakrishnan medium. You cannot collect vomiters, it is useful, it won't be useful. We also take water samples and food samples, and there's also a note on transportation of the stool sample. It should be transported in 30 ml of McCartney bottles with VR medium or alkaline peptone water. The rectal swab must be in Carey Blair medium, and it should be 1 gram per ml of feces for 10 ml medium. And then plating media in bile salt agar, it should be a bedside swab for plating. Then you have direct examination of bacilli and culture to take 0.5 to 1 ml of the material into Monsour's GTTTA, also known as peptone water telluride, for 4 to 6 hours at 37 degrees centigrade or Celsius. Then you subculture the same on bile salt agar. You characterize the bacilli according to the gram stain, the motility, and serology. And then by other biochemical tests and further characterization. Under control measures, we have verification of diagnosis, notification within 24 hours, early case finding, establishment of treatment centers, rehydration therapy, adjuncts to therapy, epidemiological investigations, and sanitation measures including water control, proper excreta disposal, food sanitation and disinfection, chemoprophylaxis, then vaccination, in which you have oral vaccines, Dukoral, which is monovalent and heat killed, which requires a bicarbonate buffer as it contains B subunit of the toxin. Then we have Sancol and MORC vax, which are bivalent, which do not require buffer, and UV col, which is similar to Sancol. Moving on to health education measures, you teach people about ORS, early reporting, food hygiene, hand washing post defecation, and promoting consumption of cooked hot foods with clean water. And then, of course, surveillance. There are other small notes, not so important notes, on community engagement, ending cholera, roadmap to 2030, and cholera kits. Cholera kits, if you want, you can remember. They might ask it as a trick question in competitive exams, I guess. Then typhoid fever. Then we have the problem statement, the epidemiological determinants, in which the agent is Salmonella typhi. But when you say enteric fever, it can be caused by typhi and paratyphi or paratyphi. So typhi and paratyphi are two possible organisms for enteric fever. Then we have reservoir, which in the cases are carriers. More than 1 year are chronic carriers. Source of infection. Host factors, age, sex, and immunity. The incidence is more in males, but however, Female carriers are more common. And environmental factors, there's a higher incidence in the rainy season because of the due to the increased fly population. Incubation period is 10 to 14 days. The modes of transmission are fecal-oral or by urine contamination of food. The clinical features, the keywords here are stepladder fever, pea soup diarrhea in the early stage, leukopenia, rose spots during the second week. They describe this rash in detail. And then the most frequent complication is intestinal hemorrhage, which can be fatal sometimes. Lab diagnosis involves microbiological analysis, serological analysis, and there are new diagnostic tests like IDL Tubex, which is a new alternative to Vidal, and Typhi.M. So, how do we control enteric fever? So, we deal with the reservoirs. Firstly, cases, early diagnosis, notification, isolation, treatment, disinfection, and follow up. And for carriers, we have identification, treatment, surgery if required, surveillance, and health education. Disinfection of cases is a bit important to know. Then sanitation and immunization of risk groups using the VI's polysaccharide subunit vaccine given subcutaneously or intramuscular, and then TY2/A oral live attenuated vaccine. So, the schedule, route, dose, safety, and precautions. Next, food poisoning. We should know what is food poisoning, who are the high risk groups predisposed to food poisoning, and the types. Can be non bacterial or bacterial or viral. Most common agents are Salmonella typhi, Staphylococci, botulism, Clostridium perfringens, and Bacillus cereus. So, each of them are described in detail using these following headings: agent, source, incubation period, mechanism of food poisoning, and clinical features. And there's an important table differentiating cholera and food poisoning. And along after that, you have the various differential diagnoses for food poisoning, which is also a bit important, especially in case of emergencies. Investigations, you need to get a complete list of the people involved, in detail lab investigation, animal experiments, serology or antibodies, environmental studies, and data analysis. Animal experiments are not that essential, it's fine. And prevention and control measures, we have food sanitation, in which you have to do meat inspection, ensure personal hygiene, food handlers, food handling techniques, sanitary improvements, and health education on the same. Then refrigeration of foods and surveillance. Next up, we have amoebiasis, in which you know about the agent, reservoir, and period of communicability under agent factors, host factors, age, sex, and immunity. Incidence equal across both sexes, and it's cell mediated immunity that you have to take note of here. And of course, environmental factors like hygiene, sanitation. Modes of transmission can be fecal-oral, sexual, or via vectors. The incubation period is 2 to 4 weeks. Prevention and control measures can be primary or secondary. Primary measures include sanitation, ensuring hygienic water supply, food hygiene, and health education. Secondary, as always, involves early diagnosis and treatment of symptomatic and asymptomatic cases. Next, we have soil transmitted helminthiasis, which you have to know the modes of transmission in general for any helminthiasis. Eggs can be transmitted by contaminated food or contaminated water or contaminated soil combined with the habit of not washing your hands before a meal. The first disease here is ascariasis. You need to know about the agent, reservoir, infective material, host, environment, human habits, and the period of communicability. That is, until all fertile females are destroyed and stools are negative, this disease it remains communicable. Incubation periods can stretch from 18 days to many weeks. By the way, EF stands for epidemiological features. Next, we have hookworm, in which you should know about the agent, reservoir, infective material, and period of infectivity. Host factors, age, sex, nutrition, host parasite balance, and occupation. And then environmental factors, you have to consider the soil, temperature, oxygen, moisture, rainfall, shade, and human habits. Do note that floods are unfavorable for transmission of this disease. The incubation period is 7 weeks for Necator americana and 5 weeks to 9 months for Ankylostoma duodenale. The effects of the disease can be on an individual level and community level that you should know. Coming to whipworm, the last salt transmitted helminthiasis for today. We have the agent factors and then the incubation period, it's not really given, and the effects of disease in mild, moderate, and severe infection. Prevention and control measures are primary and secondary. Primary include ensuring better sanitation and behavioral changes via health education. Secondary measures include treatment with early diagnosis and treatment with albendazole 400 mg single dose, contraindicated in pregnancy and when less than 2 years. Then mebendazole 500 mg, levamisole, and parental palmoate. We also have to treat anemia and other complications as well. And finally, we have chemoprophylaxis for high risk groups and the drugs used. So that's it for today, guys. Thank you for watching. Hope this was useful and stay tuned for parts 2 and 3 of this chapter.